Good afternoon, and welcome to Understanding the PHR's Place in Your Population Health Strategy, a webinar tweet chat combo from HealthSystemCIO.com, sponsored by MedicaSoft. Just a little housekeeping before we get started. My name is Anthony Guerra, and I'm the Editor-in-Chief of HealthSystemCIO.com, and I will be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our Managing Editor and Director of Social Media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can view the tweet chat in the Media Viewer panel on the right-hand side of your screen. We'll also be using the Q&A panel today. Type in your questions as they occur to you and send them in. Leave the default set to all panelists, and we will take them later in the program. And you can download the deck by using the URL on your screen. It's at the bottom of our slides, and it's also been set out in the chat box. Just so you see how we're going to spend our time today, first we're going to have our panel discussion featuring Mark Jacobs, CIO of the Delaware Health Information Network, and Mike O'Neill, CEO with MedicaSoft. So without further delay, we are going to jump right in. Mark, can you give us an overview of your organization and your role there?
Sure. My name is Mark Jacobs. I'm the Chief Information Officer for the Delaware Health Information Network. And DIN is the nation's first live statewide health information exchange. We consider the DIN, as we call it, as saving time and money and lives. We also create efficiencies for doctors, patients, and practices who send us clinical information so we can provide that back to caregivers and now patients.
Very good, thank you. Mike, a little bit about MedicaSoft.
Sure. Well, I'm CEO here at MedicaSoft, and we're a healthcare IT company with what we think is a unique data platform that we use to build solutions for health information exchange, for personal health record solutions that we're going to talk a little bit about here today, and also for EHR, electronic health record solutions for healthcare providers. We started down this path with an idea that if you can actually get your data right, or we would probably say get your platform right, which is data and a combination of the right services to really make it useful, then you can do some interesting things to engage patients in their own health and wellness.
Okay, very good. We'll jump right in. So, Mike, let's stick with you. What is your definition of a personal health record? And maybe give us that as maybe distinguishing it from an electronic health record.
Sure. Right off the top, often we use personal health record to describe things that you would use as an individual or a patient versus an electronic health record that's something that your doctor, clinicians, or healthcare providers would use. To us, the personal health record is something that, first of all, brings together all of the information that you as an individual need to understand your overall health and your wellness profile. And that gives you, in addition to the data and the information, the tools that you need to actually own and manage your health and wellness. That includes conditions or illnesses that you might have, of course, but also factors that you need to pay attention to keep yourself healthy, which is what we mean by wellness. In terms of bringing together data, that does include data from your doctors and from hospitals. That is probably going to come from EHRs, or electronic health records, but it also includes the data that you might provide as an individual from personal devices, if you're a user of fitness trackers or Apple Health or devices, applications on your mobile phone. It also means that you really want access to some tools to help you use that information, whether that's educational information or access to care plans, even things like secure messaging so that you can safely share your health records with your doctor. Maybe it's the ability to manage information for your children or for others in your care, and so forth. That's generally, if we bundle that together, access to your complete health record and the tools that help you use it, that's what we mean by a personal health record.
All right, very good. Let's just stick with you here, Mike, and then we'll go to Mark. To what degree do you think PHRs are being embraced?
Well, I think this is a very active field today. Honestly, initially, PHRs were really begun more as what's often called a patient portal. And for those in the industry who know that the patient portal adoption was driven, quite honestly, largely by healthcare providers needing to meet what's referred to as meaningful use requirements for IT adoption in healthcare. This started the trend, and it was a great first step to have your doctor at least let you access your health records electronically. There were some challenges with that, and we probably all have some familiarity with the situation where each doctor or each clinic that you visit maybe has a different portal. It gives you access to the slice of your health information that they have, but it's fragmented, let's say. That's a great start. It kind of got us into the electronic world. But where PHRs are going, and what I think has gotten people interested now is, well, the ability to combine all of that data, to not force you to go to a handful of different individual portals where you have to remember your password and so forth. Bring it all into one place and start to organize it for you. From our point of view, as a software vendor, we get involved in making a lot of the features easy to use and helping you understand all of that information. We really think that working with HIEs like Din and working with Mark and his team, that plays a huge role because they can bring the data from multiple healthcare providers, from multiple hospitals, into one place and start to make it available to individuals.
Very good. Mark, you want to give us your thoughts about to what degree PHRs are being embraced?
Well, depending who you ask, PHR are being embraced by the patient today in many different areas. So, for example, if you were to ask a hospital how do they use it, you might get a little bit different answer than the patient. But what everybody's really concerned about is how do I improve quality and how do I improve care for the patient and also for myself. So anything that encourages transparency, i.e. the PHR, will help the patient participate in their health a lot more. And so I think that's how folks are seeing the use of the PHR over time occur. In DIN, we see it pretty dynamically changing. We see more patients wanting to know more about their information. They don't only go to the same hospital anymore. They go to a doctor in one area. They may go to urgent care. And what's nice about the health information exchange and providing that information through a PHR, it's there for the patient wherever they go. It's transportable. They could carry it around with them. They could take it anywhere.
Very good. Very good. All right. Mike, let's go back to you here. Are patient segments, particular patient segments, like those with chronic conditions, more likely to use a PHR? And if so, how can PHRs be made more relevant and useful for healthy patients?
Sure. Well, I think what turns out to be true is there are many different groups or population segments, if you will, who can make use of PHRs in different ways. People who suffer from chronic conditions, that's certainly a group that has the need to bring health records together, often from multiple doctors and multiple specialists. They have a need to track that information over time. They often have a need to look at a care plan that can be complicated and then communicate back to their doctor about how they're doing on that plan. That's a perfect application for a PHR, to bring together data from more than one physician, to help you understand it, to help you monitor it over time, and communicate securely back to your doctor. So chronic condition, that's definitely a segment that can benefit from a PHR, and I think they are beginning to show more usage there. But I think there are others. Maybe at the other end of the spectrum are folks who are fortunate that they don't suffer from an ongoing condition. They're generally healthy, and their interest is, how do I stay that way? So they may be interested in tracking exercise information. They may be interested in nutritional guidance. They may be interested in communicating back to their doctor how they're doing, maintaining weight and blood pressure and all of the elements that keep them healthy. That's another population with a different use, but finds a lot of adoption of PHRs. And you can imagine others. Families, parents with children are often looking to manage the health situation, immunizations, vaccinations, and so forth for their children. You may be in a situation where you're the caregiver for, let's say, an elderly parent or something like this. So families often have a need to be able to manage the health and wellness of family members. The elderly population, I think today, is more and more active and interested in managing conditions that they may have and staying healthy and so forth. So I think as you really dive into it, you can start to segment out the population where they have different reasons, different objectives, but they have a common need to see their overall health records, get information that helps them understand it, and then tools that help them work with their doctor on managing it.
Yeah.
Go ahead, Mark.
Yeah, so what's really unique is when you get a PHR to allow the patient to be able to meet their goals. So if they're a diabetic and they need to be they need to monitor their glucose level, it's nice to be able to have a tool that they could see and track that information over time, or even their blood pressure and the like. So definitely a PHR for patient goal setting is a tool that they can use to help them achieve those and meet those with their provider.
Very good. All right, Mark, let's stick with you here. How should hospital and HIE IT executives view the PHR in terms of their patient engagement and population health strategy, and including social determinants of health? What information should they be able to send and to receive from it? So get me from the CIO perspective of a hospital or a health system. How are they thinking about the PHR these days that they're not controlling? It's a patient under patient control. What do they need to be able to do to satisfy that patient?
Well, I think the evolution is occurring with greater use of a PHR with more useful information. So some hospitals still feel that information needs to be provided through that organization, and they have a whole series of reasons why that's important, because they want to ensure that the integrity of that information is accurate and that information is secure. In DIN, we have our PHR called Health Check Connect, and we provide data from every single provider and every single point of care in Delaware. And so what that means is in their PHR, which is, again, Health Check Connect, that information comes into the vision of the patient with the use of the tool. So hospitals in Delaware have learned to leverage that, and providers also to have DIN be their trusted delivery provider. And that's also growing beyond just feeding an EMR and our community health record to a personal health record. So over time, we will see more use of that information. Also, the whole issue of social determinants, having that information with the provider helps in a number of things with the patient. So the PHR should be a conversation tool between the patient and the provider with the information to support both the providers, what the providers are looking for in terms of working with the patient, and the patient working and meeting those goals, as I said earlier. So I hope that answers your question.
And you know, Anthony, one thing that, if I can add, that I think Mark and his team at DIN have done very well when it comes to PHRs and HIEs is DIN lives in an ecosystem of hospitals and physician practices where each provider has a relationship with their patient set. And I think the DIN team has done a great job of figuring out how to position the PHR from the HIE in relationship to the relation that the patients have with their provider. That's something that you don't want to create confusion. You want patients to feel like they have a relationship with their doctor, but the HIE is able to provide your health records and information from hospitals, labs, and so on that span just that one relationship with the doctor. What we've tried to do at MedicaSoft is give the DIN team the tools to manage all that data and then present it to patients, to present it to providers in a way that prevents that confusion and makes it feel like, from the patient point of view, it's all one team that's helping them with their health.
Yeah, and that's a good point, Mike, because with Delaware and our personal health record, you don't have a PHR for with your patient. You can get it from DIN. We could integrate our PHR into your PHR with your doctor. We have that integration. So we have many ways to be able to deliver it for not only the patient but also the provider in terms of their delivery and integration with their patients through their own PHR. So.
All right, very good. Very good. All right, Mike, let's start with you here. What standards or formats, such as HL7 and FHIR, must the data be in for PHRs to accept it?
Well, sure, it's a great question because, as we know, interoperability has been, top of mind for everybody for the last couple of years. First and foremost, we try to take the approach that, we will take the data in whatever form we can get it and then process that and make it something that's usable. Now, in practical terms, the most common formats and the easiest to exchange are standards-based formats. HL7 messages and continuity of care documents, actually the entire CCDA document library, for those of you who are familiar with that. These are standard formats that we've all as an industry agreed on are useful for exchanging information. That said, the standards always have local implementations, and so the ability to not just parse them, but to do some normalization of data, maybe to map between code sets and so forth. This is something that we do as part of what I referred to earlier as the platform. You can take the data, that's one thing. A platform approach is how do we make that data useful. So even starting with industry standard formats, there's some processing, there's some normalization, there's some things like patient matching and so forth that go on so we can assemble useful health records. Since you mentioned FHIR, HL7 FHIR as a standard, it's actually something that we use as our internal data model. FHIR is used increasingly these days in the discussions of interoperability and how we can exchange data. But we find that there's actually value to use it as the common format that will translate any form of health information into FHIR resources. That gives us a common language that we can communicate back and expose that data in standards-based ways.
Very good, Mark.
And as far as the standard formats, one of the unique things about our health information exchange is we accept data in any format. For example, we take data in through HL7 format. We take them in through CCDA format. We also take them in through text format sometimes. So the challenge becomes is how do you take this stuff in and make it available to a PHR? And through the PHR in Delaware, we have an open platform which is leveraged, which the application rides on top. So what that means is we could leverage standard formats, be able to feed into the PHR and also feed out from the PHR to an EMR or even another PHR that might be unique to a hospital provider. So the open platform allows us to do that, and we don't typically worry about saying we'll take only one format today. So.
Very good. Very good. All right, let's stick with you here, Mark. What are the privacy and security issues that must be taken into account when sending and receiving information from a PHR?
Well, there's always privacy and security considerations that we need to be diligent upon, because without that, we won't have trust between the provider and the patient. And it's not just having it with the patient, it's the provider and the patient in that relationship. Some of the biggest challenges we hear are sort of anecdotal in terms of the patient. The biggest is that we have many different PHRs that are used in Delaware beyond just what the HIA provide. We would like it to get to the one personal health record, but that's not the reality. Typically, from the patient comes back concerns within those providers. How did my information get into the DIN? And I think that the patient is generally concerned because they don't follow all the connections and the way that information is distributed. The biggest thing beyond that is the patient always is concerned is my data protected? Finally, patient matching is always in the forefront because we get data in from all different formats from all different places. So we've become very good at doing patient matching, and that's done in concert with our data contributors today. So the privacy officers typically are accepting today of DIN with the personal health record. There's more work to do, but I think it's gaining in trust and popularity with the privacy officers.
I think that's very true, Mark. I think DIN has a strong reputation, a trust reputation in the community, and what we've done working with Mark and his team is to help them build on top of that based trust, because they know how to protect the security and privacy of information. As soon as you start to present that information to individuals in a PHR, there's actually even more granularity that you'd like to have in security and privacy. And what I mean is, there may be some types of information that you're comfortable sharing with everyone, with any of your doctors, or maybe with a trusted caregiver. There may be other parts of your health records that you really want to keep private. And then there's some that may be in between. You'd like one specialist to see maybe some of your counseling sessions, for example, and not others. At the data level and at the HIE level where Mark and his team lives, they have the ability to do that if we can provide them with data that's broken up with enough granularity and that can have privacy policy applied to it at an individual level. So that's something that I think we've been able to team up and work with the DIN team to do that at a technical platform level, and then translate that into what does that mean for individuals, give them the comfort that they can manage their data and be sure that they're only sharing what they want with the people that they actually want to authorize to see it.
Very good. Very good. All right, Mike, let's stick with you here. Once data flows into PHRs, how can analytics be brought to bear on it for the purposes of population health? Is there a void in the market for these types of offerings?
Sure. Yeah, I think that this is a growing area of interest and of need in the market. And I should probably say for analytics, which is very broad, there are a couple of areas that we think about. One is actually patient-facing, since we're talking about the personal health record and tools that patients would use. There is a little bit of a gap between just showing somebody their raw health records and helping them actually gain information from that. And so there can be analytics there to pull things out in terms of trends or advice, or even presenting them with educational information that's based on the conditions that they have and that are really relevant to them. That's actually a form of analytics, and that's something that we do that goes in a PHR and helps people work with their data. From a population health point of view, we're talking generally about looking across an entire set of people and looking at what are the health outcomes that I'm achieving, and am I efficient in my delivery of care, which has an element of cost to it, but also of productivity and workflow. And this is something that, first of all, we have to do in a way that protects individual privacy. So we're typically talking about looking at de-identified data, where you can't tell any one person's health information, but you can look in aggregate across a population, and now you can start to combine things like the rates of occurrence of a certain condition, the types of treatments or medications that are applied, what is their effectiveness, and what is their cost. Particularly if you can, as Mark and the DIN team can do, if you can add insurance claim information along with the clinical data. So this is absolutely something where I think there's a big opportunity in the industry. It's something that we're really enjoying working with the DIN team to combine that clinical data, claims data, and an analytics capability, and really give healthcare providers and payers information they can use rather than just access to raw data.
Very good. All right. We're going to go with our Ask a Co-Panelist segment now, which I always enjoy. So, Mike, why don't you throw something out there for Mark? Maybe stump him. Give him a hard time.
Sure.
Well, so in general, we don't ever talk about age in business relationships. So this is not about personal age, but actually the age of DIN as an organization. It's a really interesting thing. The DIN team is one of the longest running HIEs. I believe that I'm accurate on this in the country. And so they've lived through some generations of health information exchange, of interoperability and data sharing, all the way up to the current time where we're talking about actually getting individuals or patients involved in accessing this data. So really, Mark, what I'm wondering is, from your vantage point, how have you seen the evolution of HIEs over the last 8, 10, 12 years that you've been involved? How has that been helping individuals with their own health care?
So that's a good question. So there was a time back in DIN evolution, and also with other HIEs, where we delivered information, whether it's through results delivery or we delivered through a community health record portal, and that was a portal to the physician or the provider. What's changed over time is as DIN and our stakeholders became comfortable with an HIE, they then evolved to a level that they could query the HIE. And as then we grew into the stage where we delivered clinical results to an EMR or electronic health record. What's really changed is now that evolution is occurring to the patient engagement side. So DIN is truly a learning ecosystem, and we are definitely evolving with the time. So what was acceptable years ago as the core solutions and information we provide has now grown well beyond that. So the HIEs never stay stagnant. They change with the time. And I would say, over time, we'll be more, as more value-based payment programs come in, DIN will be even more critical to providing not only PHR, but analytics back to both patient and provider in many, many different levels. So,
all right. Okay. Mark, you got a question for Mike?
Oh, you bet. I'll wing one at him.
There you go.
So Mike, you're a provider or a vendor that provides PHR solutions. I know why we chose to work with you, because of your open platform, but also your product, and it's been a great relationship. But amongst all the PHRs and all the products that provide many, many different things, as a patient, how do I choose and make the right decision of a personal health record with you? And I know why we want them to work with us.
Sure. That's a great thing. So the thing that we want to present to patients to make, well, honestly, from a business point of view, we'd like them to feel like we provide the best solution. But why do we feel that way? Well, number one, we want to help patients be able to get all of their information together into one place. Very easy to say, but very difficult to do these days. So that's something that from a software and a technology point of view that we spent a lot of time on to make it pretty frictionless, that you can get data that you have yourself, even if you are downloading information from patient portals and uploading it, that no matter how you can get it, we want to handle that for you. So that's number one, that we think we do a better job of getting all of your data together into one place. Then the second thing is, so how can we help you make sense out of that? It really doesn't do you any good if you've gotten all of this data together and it's the equivalent of having a big folder of individual sheets of paper that you can never find what you're looking for when you need it. That's really not helpful. So then how do we organize that data? How do we standardize it? How do we normalize it? How do we make it into information and health records that you can actually browse through, that you can find what you're looking for, that you can focus on lab results if that's your concern for today, or how you're doing in exercise and nutrition tomorrow if that's your concern. So that's something else that we spend a lot of time on. And then the third thing is, so how easy is it for you to share that data? You're probably interested in sharing health information with your doctor if you're spending time managing your health and wellness. Can we make that easy for you to do it by organizing just the information you want to share, nothing that you don't, and give you the comfort that you can send it securely, and then make it easy for that receiving physician to understand what you're trying to tell them in a form that they're comfortable using. So kind of a long answer to your question, Mark. The short version is, so why us, or why look at a PHR of the type that we produce? Well, you want to find something that helps you gather your data, that then helps you organize it and make sense of it, and then helps you share it and use it as you're actually day-to-day managing your care.
Very good. Those are good questions for each other. Here's another interesting feature we have. So let's try this. Give the listeners today a key challenge. You want them to go back to their health system or health information exchange and do what? Something concrete, some kind of concrete action that will help the populations, help them better serve the communities they're trying to serve, or even help them personally develop. Mark, let's go with you first.
Okay, so just a short while ago, a couple of short years back, it was very, very difficult to get at your information. That was very difficult to get on paper. It might have cost you some degree of money if you could collect all that information. We live in some exciting times. What I would challenge the listener to do is, what is important to you for your family, your relationship with your provider, the relationship in your health that you might think of, and go back and then ask the providers or ask that health system to answer that question. If you can't answer that with your PHR, I think it's very important that the patient understand that, because obviously the paradigm shift has occurred that you have to participate in your health today. And it's not just go to the doctor and treat the patient and walk out with a bunch of pills. Chronic disease is real. Patients can improve their lives, and I believe that the PHR can help do that. And definitely in providing that with all the information for every single provider in Delaware is a great asset for any Delawarean.
All right, very good. Mike, do you have a challenge for the listeners?
Yeah, I would start by just guessing here that since we're all listening to a healthcare IT webinar, that we're involved in healthcare in a lot of different ways. So that the main challenge is, when you go back after listening to this, what is the role of the patient or the individual in what you're doing? We could probably all start with the fact that we're all patients at some point. So do we have access to our health records? And if not, are we asking for it? Are we trying to make that situation easier? The other thing is then, in whatever we do for our work, whether we're a vendor like MedicaSoft or an HIE like Mark, or on the provider side or payer side, are you taking advantage of, are you working with individuals and patients as a cohort that you care about, that drives your business? You may be directly involved with patients and care delivery. How are you helping them understand and make that process easier? You may be a step removed, but they're still the end customer in healthcare delivery. What is the experience of that individual, and how does that affect what you're doing day to day, and how can you make that better? That's, I think, the challenge for all of us when we leave a discussion like this one.
All right, very good. We're going to go to our audience Q&A. So if you have a question, send it in the Q&A box now, and we will get them to our panelists. First question is for Mark. How do you manage consent, especially with regard to specially protected health information?
Well, we manage consent. The patient always has a choice, and we have features and functionality built into our system, whether they're a process, policy, and also functions within our systems to allow for that. So, for example, if you don't want to share certain lab tests with your doctor, you can not allow. You could restrict that and only show those tests that you have made the choice not to share. So there's many choices. Typically, DIN as a health information exchange is an opt-out. Basically, patient's information is available to the providers unless the patient opts out. And the patients have made choices in the past to do that. But for the most part, 99% of Delawareans today prefer their information in DIN. So we don't seem to have the challenge. I know it's a big issue that's talked around with other issues about rolling out PHRs, but we have more acceptance between the patient and the provider on this information being delivered through the DIN.
All right, very good. Another question for you, Mark. Can you talk a little more about how DIN markets the PHR to the patient and gets adoption versus a PHR that their provider may have?
Well, I just happen to be sitting here with our marketing director, and I'd like to have her comment, Stacy Schiller. And Stacy, your thoughts on that?
Absolutely.
Special guest, Stacy. Special guest star.
Special guest star. Indeed, here's my big moment. I hope I don't disappoint. So we're really taking several approaches with marketing the PHR. As our friends at MedicaSoft know, it's been a challenge introducing a service to patients when we, as an HIE, don't necessarily have a direct relationship with those patients. So we've really had to do a twofold approach. One is to introduce DIN, which we did a couple years ago through a federally funded marketing campaign. And then the second is to talk about the benefits of the personal health record and how it relates to the information that their physicians already see. And I will say that we've done a couple of direct mail pieces. We've done a lot of promotion via our social media channels, and we're also exploring one-on-one collaborations with our friends at MedicaSoft, as well as with several practices with whom we have a good relationship and who have been willing to help us really launch the PHR with their patient population. So we continue to see incremental growth in registrations, and again, because it's free, there's really no reason not to.
So,
yeah, and you know, Anthony,
good.
Sorry, Mark, I was going to say, I mentioned earlier that I think that the DIN team has done a great job because you come from a place where you've already established a position of trust. And again, not to speak for the DIN team, they're very skilled at doing this, but they have a great relationship with the providers in their market. So they've done a lot of outreach to hospitals, to physician offices, to make sure that they don't create confusion. As Stacy just mentioned, they have a structured approach to communicate to their population who is DIN and what does the HIE mean to you, and then an approach to work with providers so that it's seen as a collaborative thing so that patients don't get confused. I think that's gone very well. and I know we've talked with the team there to then build on that and maybe start targeting some of the populations that we spoke about just a few minutes ago here in this webinar. How do you market something to people with chronic conditions? How do you market to people who probably aren't seeing their doctor all that often because they're generally healthy and well, and so forth on down the line? I think they built a great base for outreach that they can now build on to go after individual populations.
Yeah, and as our discussion with Stacy a couple of minutes ago, I'm not only a good delegator, but we also have a great team at the end that is all committed to the same purpose. So I think that in our relationship with our partnership with MedicaSoft, we continue to commit to that, and we can continue to do a lot of great things, especially now with patient engagement.
Very good. All right. Question for Mike. How do you support a client implementing a PHR program? What other support besides the basic IT that you provide that helps a site entice clients to use a PHR?
Okay. Are you hearing me okay?
You sound fantastic.
Perfect. I heard a little noise and didn't want to find that I somehow got disconnected.
No, we're good. We're good.
Great. It's always a risk when we talk technology that the base technology fails us. In any case, so, you know, at a number of points in this discussion here, I've talked a lot about the technology, the platform, architecture, standards, data. I mean, as a software company, as a technology company, we love to talk about those things because that's how we build our products. But in the end, and I think as this question kind of points us towards, it's how do we use those things? How are they helpful in helping people solve the problems that they're dealing with? So what we do is to try to say, look, when we talk about things like consent, when we talk about, well, what is the granularity of access control to data and so forth, what does that mean to you? Well, that means you can be comfortable that you can have all of your health records in your PHR, and when you want to share something with one person, you're comfortable that only that person sees it, and so forth. You want to be able to say, look, what does it mean to be able to delegate authority? That's a nice technical term. To a parent, what that means is you can set up a separate account, a separate PHR for your child. That keeps all of their records separate, easily managed. But you, as their parent and caregiver, can manage that for them when they're very young, with them as they get older, and then when they reach the teenage years, there's typically in each state an age of consent, they can take over for themselves. Now, there's a lot of technology in the platform that lets that happen. But what we want to do, as I think the questioner is pointing out, is you want to explain that to folks in terms of what does it mean to you day to day in your life, taking care of your health and wellness and taking care of your family. That's what counts, and that's what we try to do.
All right, very good. Mark, a question came in through Twitter. What is the utilization rate of the PHR in Delaware? I don't know if you know that.
I don't know the exact numbers, but it continues to increase almost every day. And where we see a lot of growth is in the area of also integrating into other portals, because the patient is getting portalitis, to some degree. And it's a challenge for the patient to go back and forth. I know myself, just about trying to remember passwords. It's like, I'm getting too old for this. But the reality is the solution offers so many. So you can't just say we're providing a portal. We're providing an open platform with a PHR that integrates into many, many different things. So I would say, we continue. As Stacy said, we have a mass marketing campaign currently. We do have users that are using this today, and it will continue to increase. I believe long-term that as the hospitals and the providers are getting tired of answering the questions and fielding questions with the patient, this will evolve to the HIE taking on a lot more responsibility for fielding those questions because the information comes from so many different places these days. The patient doesn't have any loyalty to one particular hospital or provider anymore. So so utilization continues to increase. I could provide some numbers that, if anybody wants them specifically, feel free to email us and we'll get those exact numbers.
And, Mark touched on I think a really important point there in answering how PHR adoption is going, and that's the point of an open platform. The key there is there are a number of different applications and devices that individuals use. We do an awful lot that's on our phone. We have our personal fitness devices and so forth. But with an open platform approach, you're able to bring all of that together into one place. And it doesn't have to be all from the same vendor. As much as my team and Mark's team work very well together, we recognize that there can be other vendors that provide interesting solutions, and we have to be able to take an open platform approach and integrate all of this together. So we're able to handle the data, provide services, provide open APIs so that other applications can be integrated. What this translates to for individual users is a PHR that addresses all the functionality that they're trying to use in their day-to-day lives, reduces their confusion, doesn't force them to jump from portal to portal with the password issue that Mark mentioned, and really overcome some of the negative perception that earlier years ago initial patient portals created because they were inflexible, they were not open, and they were hard to work with.
Very good. I want to sneak in one more Twitter question. The Twitter community is really engaged today, and they're enjoying this very much. Yeah, we like that. How are you, I guess this would be for you, Mark, but Mike, you're free to comment. How are you approaching the UI/UX with patients? I guess that's user interface. You would know better than me. EHRs and administrators are guilty of not understanding and engaging patients. Are things like gamification, SoMe, and other avenues being utilized effectively? Mark?
I mean, we don't provide all those today, but I know that we have plans long-term for other methods that we're going to provide delivery. And I know, Stacey, your thoughts?
So I can add a little bit of context to that. Certainly as somebody who works in the field of, working with different apps and things like that, I can appreciate the need for gamification and really incentivizing, in a sense, people to use your products or services. I think that right now we're really focused on getting the functionality there with our personal health record and making sure that we're providing the services people need through it. Long term, we would love to see this become an app to add some of those consumer-friendly features like gamification to the app, in the hopes that, of course, that brings new folks on, new users on, but also, too, gives people multiple reasons to come back and use the site or use the app again and again. So we absolutely are keeping our ear to the ground on those types of developments, and certainly MedicaSoft is as well. So I would expect over the coming months and over the next year or so to really see some further development of our personal health record, and hopefully then we can be able to add some of those other elements.
Very good.
Go ahead,
Mike.
I agree. Oh, I was going to say I agree. I think Stacey's got it exactly right. It's one of the benefits of an open platform is that there are a roadmap of things that I know Din will continue to add to the PHR. Very briefly, Anthony, I know you were maybe going to wrap up. One of the things that the industry is learning in the EHR space for physicians is present them with the information that they need for the task that they're doing at the moment, and then give them the ability to dive in to details where they need to. This is the same thing that applies when we're talking about patients or individuals. Give us the information that we're interested in a very easy to understand form that doesn't make us feel like we have to turn into doctors. But if we want to dive into more detail, if we're knowledgeable, if we want to go back to even the source documents, give us the ability to do that. and that's something that we put a lot of effort into the user experience design of the PHR so that it gives you easy access with the ability to dive into great detail if and when you need it. I think that's important, and we think that lets folks like Stacy then build on top of that for all of the user-centric features that they'd like to add.
Very good. All right, go ahead, Mark.
I knew Stacy was going to be a good value add to this webinar, so that's why I invited her. But
go ahead.
Yeah,
okay, Mark.
It's a good discussion.
We really do appreciate the opportunity to participate today.
All right. Does anybody have any final thoughts, or are we good? Mark, you got anything left? Anything else?
No, I would say that the only thing I would say is this is about a patient record. This is for the patient, and I think it's critical to ask yourselves and ask as a patient, what do you want in a PHR? And chances are you'll probably get it within Delaware because we provide such a flexible tool and a flexible platform to provide that information for patients to be able to share, exchange, and make available to them, when and where they need us.
All right, Mike, any final wisdom?
No, I think this has been a great conversation, in part because DIN is doing an awful lot in this space, but also in part in the industry. The whole idea of patient engagement, empowering individuals, is a really rich opportunity space and really engenders interesting conversations like this one.
All right, very good. Well, we are going to wrap it there. When you close your WebEx window, you're going to be taken to a post-event survey. If you take a moment to answer that, we'd appreciate it. Regarding continuing education, those of you who hold the CHIME CHCIO certification get 1 CEU for attending our events. And if you need a certificate of attendance for another CEU program, you can use the final slide in this deck. You'll receive an email when our archive recording has been posted to our YouTube channel. If you'd like us to produce a webinar on the topic of your choice, you can reach out to Nancy Wilcox from our team, and you can go to our website to view our upcoming schedule of events. So with that, I want to thank Mark Jacobs, Mike O'Neill, and special guest star Stacy, who has become famous today. I want to thank our sponsor, MedicaSoft, very much for making this important conversation happen, and I want to thank you, our attendees, for joining our events. So with that, everybody have a wonderful day. Thank you.
Great, thank you.